Our panel today includes Tim Stout, who is the chair of ophthalmology at Baylor College of Medicine and director of the Cullen Eye Institute at Baylor. We also have Dr. Aniz Girach. He's the chief medical officer at ProQR. Again, remember those antisense oligonucleotides I talked about? That's what ProQR is doing such a great job developing, so you can ask him questions about that. And then we're very glad to have Kari Branham, the clinical assistant professor and genetic counselor from Kellogg, return to our panel. So I'm going to start off just asking each of the panelists to just give a little background on who they are and their roles, maybe how they got to the place they are and what they're doing. And if we could spend just a few minutes with each panelist, that would be great. So Dr. Stout, do you want to start us off giving us a little background?
Yeah, Ben, can you hear me?
Yes.
Okay. So I am a retinal specialist. I originally trained at Baylor, went away for a number of years to Los Angeles and then Portland, and then came back here about 7 years or so ago. My original PhD work was on the concept of making viruses that could infect cells that would transfer genes into cells, because we thought that the concept of gene therapy would be a potentially useful idea. So it's nice to have seen that come full circle from something that we worked on in the laboratory to something that I actually can treat patients with now. So I'm actively involved with a number of the companies that you have discussed with regards to either gene therapy or stem cell therapy or antisense oligonucleotide treatment. So I'm involved at the basic science level as well as treating patients.
That's great. Yeah, I know you've been embedded in this space for a long time and have a lot of clinical trial experience too, which is great.
I do.
Dr. Girach, do you want to give us a little background on yourself and what you do at ProQR?
Yes, hi Ben, I hope you can hear me okay.
Yes.
Great. Well, my name is Aniz Girach, and thank you very much for inviting me here. My background is that I'm a retinal specialist as well, just like Tim. But unlike Tim, after my initial 10, 12 years in academic practice and clinical practice, I moved into the pharmaceutical industry. And I've worked with the pharmaceutical industry with companies which are large companies such as Eli Lilly and Merck, and then more mid-sized companies such as Alcon in the past. And then more recently with small biotechs. And so the work that you were describing, Ben, on Nightstar and the slide that you presented, fortunately, I was the chief medical officer at that time and the architect of many of those trials. So it's great to see these trials maturing, and we hope that hopefully it provides some kind of treatment to some patients at least that you mentioned. My current role is that I'm a chief medical officer for ProQR Therapeutics. ProQR is a small biotech company based out of the Netherlands. Now, despite the fact that they're based out of the Netherlands, I'm actually based in the UK. So I trained in the UK, I live in the UK, and home is UK for me at this stage. But the company is relatively small, about 150 people altogether. And we've been looking at antisense oligonucleotides and looking at these forms of RNA therapies for inherited retinal diseases. And hopefully I'll get a chance to explain a little bit more about these AONs later on.
You definitely will. We'll make sure. Thank you, Dr. Girach. And then Kari, we've already learned what you know, but maybe you can tell us more about your background, how you got to where you are.
Yeah. So I actually have been at Kellogg since 1999. That was when I graduated from undergrad, so I guess I'm dating myself a little bit there. But I graduated with my degree in genetic counseling from University of Michigan in 2002, and I've been an ophthalmic genetic counselor there since that time. It's been amazing to see kind of how the field has grown over that time. in my role now, I mainly provide ophthalmic genetic counseling for patients at Kellogg, primarily with inherited retinal diseases. I do see some other cases of different for different clinics, such as optic neuropathies and pediatric developmental eye disease, but my main focus is on inherited retinal diseases. In addition to providing that counseling, I work with a fair number of clinical trials as well. So basically, any of the clinical trials that we're doing, I'll be engaged with those and working on identifying people who might be eligible for those treatments. I also am the coordinator for, we do the Luxturna, the RP65 gene therapy trial, and I'm the coordinator for that. And then in my spare time, the things that I like to do are kind of my own research focuses on things like genotype-phenotype correlations. So that basically means understanding why a patient with a genetic condition is affected the way that they are. And I'm also thinking about different ways that we can kind of integrate telemedicine to do the telegenetic counseling remotely. So that's it.
That's great. And you've helped us out a lot with My Retina Tracker, haven't you? You've been involved in some studies with the data.
Yeah, I'm actually, it's fantastic. There's a huge number of nearly 6,500 people who have submitted samples to the My Retina Tracker genetic testing study, and I've been analyzing that data. It's a lot of data, so it's taken me a while. But there's really interesting things, especially that'll basically be the largest cohort of patients in the United States that's been studied. So I think it's going to give us some great information about RP and other inherited retinal diseases and kind of information on prevalence of some of these diseases. So,
right, great. Okay, so I'd like to go back to Dr. Stout, and this is a pretty simple question, but I think it's important. We get this question a lot. And a lot of retinal disease patients, because there may not be a treatment that's available right away, they may not see their retina doctor on a regular basis. And can you talk about why it's important to see a retina doctor on a regular basis, whether or not somebody is having any issues?
Yeah, so Ben, I think that it's useful to see your ophthalmologist periodically if you have an inherited retinal disease, simply to monitor the progression of the disease. You know, these diseases typically tend to be relatively slowly progressive. So you don't really notice a big change. You don't wake up with vision different from what you went to bed with. But it changes gradually over time, and you learn to adapt to it. And you learn to navigate around, and you become relatively good at doing that. Unfortunately, what happens oftentimes is that you don't really understand how much vision you've lost or how much peripheral vision you've lost in with regards to rod disease, retinitis pigmentosa, or how much central vision you've lost with regards to cone disease, like Stargardt's. And so you might not notice, you might not appreciate how much vision you've lost. You can put yourself into a dangerous situation where, you know, gosh, I've been driving for years and years and I see just fine. Well, really, your peripheral vision is not as good as it was 2, 3, 4 years ago, and it's really probably not safe for you to be able to drive now. So it's a factor of monitoring how things have progressed and how that could involve lifestyle changes. Does that make sense?
Sure. And one other thing I want to have you talk about for a moment is cystoid macular edema.
Right.
Because I know there are a lot of, at least a significant number of RP patients that have that complication.
Yeah, so great question. So normally we think of retinitis pigmentosa as being a rod-mediated or at least rod-initiated problem that involves your peripheral vision and involves your vision under dimly lit circumstances. So people who have retinitis pigmentosa, even though they might have accurate central vision, will notice a decrease in their peripheral vision. They'll also notice a decrease in their ability to see in dim light circumstances. So when the lights go down, they can't see anything. And that's because it's a rod-mediated problem. As it turns out, there are a number of patients who have a swelling of the retina, who have retinitis pigmentosa, and that swelling actually involves the collection of fluid in the smack dab center of your retina, which is the macula. And that can involve a reduction in your central vision. So a lot of times we think of retinitis pigmentosa as being an inexorable loss of your peripheral vision, but in these patients, they have the peripheral problem, but they also have a loss of central vision because of this swelling or fluid that builds up in the macula. Sometimes that actually can be treated with topical or oral medicines. Not all the time, but sometimes it can. So that's another great reason to see your ophthalmologist, because you may not notice either one of these changes because they're slow, they're gradual. And again, sometimes it's treatable, so it's a good reason to see your ophthalmologist. Does that make sense?
It does. It does. Thanks for sharing that information. So, Dr. Girach, I know I did sort of a layman's stab at what RNA and AONs are, but maybe you can enlighten us a little more about how RNA work and how AONs work to correct RNA.
Yes, and Ben, Kari did an excellent job in describing what DNA and RNA was. And just to recap on that, of course, for each cell in a human body, there are 23 pairs of chromosomes. And each one of those chromosomes, you saw that slide that Kari presented, has this densely packed DNA coiled around this protein shell. And each one of these segments, which are known as genes, really codes for a specific characteristic that's there. And Ben, you described this notion of the DNA and the genome having the code, but really the message of that code being translated out to produce proteins, and the message is transmitted by these RNAs, or the ribonucleic acids. And that process is called transcription, and the process of transferring RNA into proteins is called translation. And really, that's where the antisense oligonucleotides, or oligos as they're known as, or AONs, which is short for it, are known as, and that's where they come in. They are short pieces of genetic material that can treat genetic disorders. And these pieces of genetic materials, or the AONs, really act by either editing or fixing a specific damaged portion of the RNA that's there. And that usually results in either stopping production of the faulty protein that's being produced, which is what the main problem was, or indeed instead an increased production of either a normal or slightly shortened protein version, but actually that protein, the new protein that's being produced, has got normal function. And so, as an example, our AONs, the antisense oligonucleotides, are injected into the back of the eye, into the vitreous. And what they do is they target the cells at the back of the eye, and they are able to selectively target the faulty gene, the faulty material in the RNA, and be able to selectively silence those, like you said, with a whiteout marker, and then be able to allow normal protein to be produced, or at least more normal functioning protein to be produced. And that's the essence of antisense oligonucleotides.
Okay. Great explanation. Thank you. Okay, Kari, back to you. I know that we can get a lot of questions about genetic testing for kids.
Mm-hmm.
And if you can talk about two things, what are the considerations for genetically testing a kid, but also, let's say the child is genetically tested and then needs counseling. Are they part of the genetic counseling process? And how do you handle that? That could be, I think, kind of challenging.
Yeah, so those are some definitely issues that we deal with a lot in clinic. And to talk about the first part of that first, and I guess that would be the testing of asymptomatic children. And so there's kind of a general thinking in the fields of genetics and surrounding genetic testing of you test a child if it is appropriate. And by that, I would mean, so if there's different types of inherited retinal conditions with different ages of onset. And those different conditions that you might be testing for are going to have really different implications for the family and for the children that you might be need to deal with. So for example, someone, if they have, and I saw that there was a question in the chat about it, I think I'll be answering that right now. So some types of like dominant type of RP, where they might have a very late adult onset for the condition. If you are testing the child for those conditions and it's not something that they would likely develop for another 20, 30 years, you're kind of taking away their choice of deciding if they want to know. Some children or some adults may want to know that they are at risk for developing this condition maybe another 20, 30 years down the road, whereas other adults might not want to know that. And especially if there's no treatment, they might not want to know that information and have that information weighing on them. It does become a different issue for other sorts of conditions. I would probably use the example of X-linked retinoschisis. X-linked retinoschisis will tend to have a childhood onset for that condition, and kids who have that could be at risk for things like retinal detachments and things like that. In our clinic, we especially advise those kids to be avoiding things like contact sports. So if you have an age of onset and or there's something that they should be doing, then that's definitely a time that, yeah, it is open to test children in those cases. But if it's something that's a later age of onset, the general thinking is you don't test them until there's a kind of a need to know. And I think that is going to be evolving more over time, depending on different treatments that are being developed. So if we had a treatment and we knew that early intervention was something, and I'm talking an FDA approved treatment, not necessarily a clinical trial, but if you knew that there was some benefit to getting the treatment earlier, then that could potentially be a reason why you would consider testing earlier in childhood. But it really is an important discussion to have with the family and the healthcare provider to talk about when the best time for that sort of testing to occur. The other part of that question was about, so we do test children all the time who are already showing symptoms of the condition. And we do very much try to involve them in the testing process, but that's definitely going to mean different things for different children at different ages. So if it's, say, a 5 or 6 year old that we're doing testing on, that's probably going to be as simple as, you know, we want to get a sample because the doctors and your parents want to understand as much as we can about what's going on with your vision. Someone in their teenage years, say, then there would be different kind of implications. They may be approaching the age at which it would have, they may be thinking of having kids. That's late teenage years, not early teenage years, but thinking about the age at which they're having kids. And so that's something that they should be aware of, that they potentially could be at risk for passing this on to other children. I have a lot of teenagers and young kids who are completely disengaged when they're in the session with the family talking about this implication. So pretty much for everybody, kind of the standard of care for anyone who sees our clinic, and I think a lot of genetics clinic, is all of the families get a letter of explanation kind of explaining everything regarding the inheritance of it. So that's something that can be shared with the kids when they get a little bit older. And we always encourage them, you know, this is something you can understand now, but also think about later when you're thinking about having children of your own, if there is a risk for other members of the family to be affected. So it's really going to be different for all families and depending on the kind of developmental ages of the kids.
Sure, lots of considerations. And Dr. Stout, I see you've raised your hand. I think you have something you want to add.
Yeah, so I totally agree with Kari, and this is very much a patient and family specific issue. And sometimes people want to know, and sometimes people don't want to know. And as Kari pointed out, there's benefits and downsides to knowing and understanding. One of the things that Kari didn't mention is a scientific issue, but it's more than just a scientific issue, and that is knowing different patients' genotypes helps drive clinical trials. You know, Aniz is doing a clinical trial right now on a specific mutation for CEP290. And I think one of the reasons that Aniz is doing that clinical trial is because a number of people who had Leber's congenital amaurosis decided to get their genotype measured, tested, and it highlighted a common mutation that allowed Aniz to say, you know what, that's a target that we should go after. That's something that we can help with for a variety of different reasons. So another reason for getting genotype is not just the what is it my child or what is it that I have, but it's how many other people in the world have this problem, and is this a targetable problem, and could we convince ProQR or Nightstar or AGTC, et cetera, to target this particular change for therapy. So it's
right.
It extends beyond the what's right for my family. It also extends into the, well, if there are enough people that have this problem, is this going to be a target?
Right. I think that's a good point. And a lot of the clinical trials, Aniz, maybe you can enlighten us, but I know they enroll people at a pretty young age. I mean, Luxturna, the clinical trial for that, I know they treated kids, I think in the trial, as young as 4. So depending on the condition, that might help. Dr. Girach, how young are you recruiting for the CEP290 and USH2A trials?
Yeah, so it is important to note that, of course, ideally would like to recruit patients as young as possible, depending on the disease. But of course, it can be very difficult sometimes to have very young patients in a clinical trial because you can't really fully establish both safety and efficacy of the drug.
Right.
If we take, for example, the CEP290 trial, which is the phase 2/3 trial called Illuminate, the youngest age is 8 years and above. That's what we're recruiting for. We'd like to look at even younger patients, and we've got plans coming out soon, if it wasn't for the COVID situation, for trying to start off a trial in even younger patients. But currently it's 8 and above. When we look at ushers, it's slightly different. Typically ushers patients, although they're symptomatic in their younger age groups, usually the vision doesn't deteriorate wholly until the patients get much older. And therefore, what we want to do is try and pick up patients when they've got some peripheral vision loss that's already occurred. And typically those are in patients in their adult stage. So we're looking at enrolling patients that are usually 18 or above. That's the usual cutoff at this stage in time. But I want to just come back to what both Tim and Kari were mentioning about the importance of getting genetic testing done, because in addition to what Tim has just mentioned, many trials will have inclusion or exclusion criteria that will require you to have a formal genetics test done, usually by a clear approved laboratory, as Kari was mentioning previously. And therefore, if you don't have a genetic test done, if you don't know what your mutation is, the chances are you may not even be able to get into a clinical trial at this stage. And even if you do, ultimately, when a therapy is approved, like Luxturna, it will only be approved usually for people who have had a genetic confirmation of the disease that the drug is supposed to test. So it's really critical to have widespread genetic testing done as soon as possible and as widely as possible as well. And I think kudos to the FFP for really leading the way in terms of the MyRetina tracker and also many of the testing methodologies that are out there now for making this happen.
Sure. Good point. It's almost 12:30 here on the East Coast. So Chris, why don't we open it up to our participants to ask questions for the next
Sure.
hour or so.
Absolutely. So there was several questions that came in, and I think one of them I wanted to direct to Kari right now. Right now, so Brent sent in a question and basically was talking about genetic testing and genetic counseling. And his question was really about the genetic testing that, from when he was tested, the counseling was not available, and he feels kind of shortchanged with that. So what are your thoughts about someone having genetic counseling done post-test that may have happened years ago?
So I think if they have questions, that's a completely appropriate thing to happen. Sometimes people may not have questions about their test results. Sometimes it was explained to them very well, but I think absolutely. And there are a couple of probably different ways that they could go about doing that. Most larger cities are going to have genetic counselors in them. And so that's something that you could always take your genetic testing report and just say, I already had this genetic testing, and presuming it, I don't know if it did or did not identify a genetic cause, but they could always go through that information. There actually are also programs that do telemedicine anywhere. I would use an example of Informed DNA. They are actually now providing genetic counseling for patients through with the Foundation Fighting Blindness or My Retina Tracker program, but they're just a telemedicine program. So they can basically do a genetic counseling session with anyone across the country. And they do actually have an ocular genetics team who specifically is kind of trained in these conditions that see someone. So I think that's very appropriate if you have questions that are unanswered of talking to someone more either locally or through this telemedicine way of going about getting genetic counseling done.
And sometimes insurance will pay for that as well, right?
Yes, and to be honest, I don't know exactly how it works with Informed DNA and their counseling that they're providing, but for genetic counseling seen in clinic, then absolutely that's something that frequently is covered by insurance company. But of course, all insurance companies are different.
Of course.
Yes.
Of course. May. Right.
Yes, they may pay for it.
Great. Another question, I think, for Dr. Stout. I think you were going to want to address this one live as you commented. So is there any research right now for the MANTI T1 gene with patients who have a form of LCA?
Yeah, great question. That specific gene, there is not a clinical trial that's ongoing right now. However, I do know that there are, I think there's 2 different companies that are interested in that particular gene, and they are embarking on preclinical studies to look to see whether or not gene therapy would be appropriate for that disease. So that particular gene, no trial now, but stay tuned. There may be.
Great. And this question kind of goes out to everyone. Right now with COVID-19 and the marketplace, what is happening with genetic testing and clinical trials?
Aniz, you want to
I could
take
respond.
that? Kari?
Go ahead, Kari.
Oh, I was just going to say, so this is based on, I think this is, again, as we all know that all the states are kind of differing in what they're doing. So in the genetic testing companies are actually still out there and can still do the genetic testing. I haven't heard of any of the genetic testing companies that are not accepting samples for genetic testing. I'm going to speak specifically about the clinical aspects of it, but it will relate to the clinical trials as well. In our own institution, until very recently, they really were only seeing emergency kind of cases. So trauma, a sudden loss of vision, that sort of thing, anything that was emergent that needed to be seen. We are phasing back into seeing patients now, and in the not too distant future, hopefully if all continues well, we'll be able to just kind of see our regular run-of-the-mill patients. So we aren't really doing much genetic testing now. I actually am calling a bunch of my patients with genetic testing results. That's how I've been spending my work from home time. But the labs are still going. It's just a matter of when, as we mentioned, the genetic testing has to be submitted from a clinician. So you typically would have to have an appointment in order to make that happen unless it's done via telemedicine. So that's my experience.
So let me comment, and I totally agree with Kari. Our department has, for the past 2 months, largely been doing urgent or emergent clinical visits. We have now expanded into, we're now at 25%, and next week we'll start at 50% of our clinical capacity. But you know, one of the great things about genetic counseling, and one of the great things about talking to patients who have genetic diseases, is telemedicine is perfect for this situation. You know, I've had a number of conversations with patients who've had genetic disease, that has been diagnosed with genetic disease, and we will mail a kit to them where they can get they can sample their saliva, they can mail it in for genetic testing, and so it's actually something that can be done remotely fairly effectively. With regards to the clinical trials, we have not started back up seeing patients who are a part or are candidates for a clinical trial. I suspect that that's going to start probably in the next 3 weeks or so. But most of our clinical trials have been put on ice for a period of time. And so the concept of genetic testing and the concept of discussing genetic results with patients, perfect for telemedicine. The concept of coming in for a clinical trial, probably not for the next 2 or 3 weeks. And of course, that's obviously going to be affected by what happens with COVID.
And maybe, Tim, I can layer my thoughts on top of that. Our experience has been, we're running global clinical trials. For example, if I take the SEP290 LCA program as an example, we have over 20 sites that are participating within that trial. And they're based predominantly in Western Europe and the States. If I split that up, in the States, you're right, Tim, generally most places have been in lockdown at this stage and are not running active clinical trial participation at this stage. Although we're seeing, like you said, and in your side, we are beginning to see the green shoots of things opening up again. So that's great news, and we hope that over the next few weeks would get some activity back and up and running again in that area. Europe is actually a very mixed bag, we find. There's areas, in some places, and you may know which countries these are involved in, typically where there's total lockdown. There's nothing going on at all. And there's other areas we actually find that there's actually normal clinical trial activity going on. So that's really a real paradox and a real extremes of examples in Europe. Europe also is now beginning to see, in Germany and other places, in my home country, UK, things are opening up gradually, rightly or wrongly. But I think that we're looking towards opening up the clinical trial scenario, the clinical trial arena, slowly over the next 2 to 4 weeks, I think.
Thanks.
Perfect. There's a few questions that I was looking at, a lot of similarities. So if people have been tested in the past and they have entered their information in my Retina tracker, is there anything they need to do to see if there's new treatments available or if they qualify, or should they be genetically tested again? What's the process for those people that may have already had genetic testing and are in the my Retina tracker registry?
Well, in terms of whether or not there's a clinical trial that is ongoing, I really would encourage everyone to go to clinicaltrials.gov. It's a website that's run by the government, and it lists almost all clinical trials that are ongoing. Now, it doesn't adjudicate the biologic sense behind those clinical trials. So there have been some clinical trials that have been listed on clinicaltrials.gov that are probably not likely to be beneficial, but it's a great source to go to. in terms of whether or not there's clinical trials. And the testing and retesting, I'll leave to Kari.
So I would say it depends on what the results of the testing were the first time around. If they identified a clear genetic cause, there's not really any reason to retest. If the results were ambiguous in some way or negative, then that is something that you could consider retesting. But again, it is going to depend on what you were tested for originally. So if you were tested for maybe 3 genes the first time and it provided inconclusive test results, then absolutely, it's a great idea to have testing again. If you were tested last year on a large panel of 285 genes, say, then there's not really reason to test you again at this time. So it depends a lot on what the results were and what you were tested for the first time around about whether or not there is a need to do retesting. But assuming it was a positive result, that there's not really any question that this is the cause of disease, then there's not really a reason to test. Some of the clinical treatment trials are retesting people when they enter that clinical trial. That's going to be very trial dependent as far as what's done, but some of them are looking at, okay, a really broad panel, whereas maybe you were only tested on a small panel in the beginning, but it would be that they would have to have reason for you to be entered in a trial, as in a positive mutation the first time around to get into the trial, but some of the trials are reconfirming that information once you do enter the study.
And I just want to add one quick comment. When you're in My Retina Tracker, you're not necessarily going to get notified about every trial. So as Dr. Stout was indicating, you need to be proactive. But when you are in My Retina Tracker, your data, your information may be seen by a lot of researchers and companies that may not be launching a clinical trial tomorrow, but they're looking at populations of patients for a trial that's a little further down the road. So just by being in My Retina Tracker, you're getting on the radar screen of therapy developers, even if they don't reach out to you.
Great, thanks, Ben. There's additional questions that are coming in regard to vitamins and supplements, especially with vitamin A versus, when you're looking at both RP versus Stargardt. What are some of the highlights and precautions that people should be aware of? And is there any more information they can learn about vitamin A?
I guess I'll take the vitamin A question. It's clear that vitamin A and vitamin A congeners or vitamin A-like molecules are very important for vision. And clearly, if you have a deficiency in vitamin A, it will cause visual problems. What's not clear is that replacing or supplementing or giving more vitamin A will solve every problem. Clearly, replacing vitamin A in patients who are vitamin A deficient solves the problem. The question is, does taking vitamin A make people with retinitis pigmentosa better? And the answer is, we don't really think so. There was some early data many years ago that suggested that maybe it made the electrical activity of the retina a little bit better over a long period of time. But that certainly didn't pan out in terms of loss of peripheral vision or improving night vision or cystoid macular edema or other things. So I don't think that supplemental vitamin A is a panacea or is going to cure most inherited retinal diseases. The way I describe this to patients is, look, vision is a very, very complicated process. Light has to come into the eye. That light information has to be converted to electrical information, and that's a remarkably complicated thing. Helping out one part of that may not solve the different problem. And it's kind of like if my car is out of gas, it's not going to run. Now my car needs brake fluid as well, but replacing brake fluid in a car that's out of gas isn't going to make the car go any better, run any better. It's not solving a problem that's common in retinitis pigmentosa. So in general, do I have a problem with people taking vitamin A? I don't, unless they take mega doses. But the studies have shown that it doesn't really help most people who have retinitis pigmentosa. Kari, I don't know, or Aniz, if you have any other comments about that.
I was just going to say, you know, part of the challenge of the studies when they were doing like vitamin A and RT is most of those patients weren't genotyped. So it could very well be that it may be beneficial for some types of RT, and it's maybe not at all for other types. You know, we generally take the approach in our clinic, and this is in general, everyone should consult with their own ophthalmologist and physician about what's the right thing to do for them. But in general, we're just kind of recommending taking antioxidant vitamins and not necessarily the high dose. But again, that's going to be really different from clinic to clinic and patient to patient.
And I think one other important comment to make, Kari and or Tim, is vitamin A can be actually harmful for certain inherited retinal conditions.
Yeah.
So like Stargardt disease, do not take vitamin A.
That's correct. And that gets back to Kari's point. You know, the studies that looked at vitamin A a long, long time ago didn't really look at what the genetic basis for their disease was. So, you know, I'm loath to start patients on vitamin A in general, and I'm very concerned that in some situations it may be harmful.
Great. I'm going to throw it over to Dr. Girach. He's been noticing too, and we've been looking at there's a lot of questions that are coming in around LCA. So Dr. Girach, wanted to throw it over to you to address a variety of those questions that are coming in.
Yeah, a lot of questions I'm seeing there about whether we have a trial for SEP290. As Ben has previously mentioned in his talk, you may have missed it. We do have a phase 2/3 trial up and running, which is looking at SEP290 and a specific mutation on the SEP290 gene. So that's really important. The details are on our website and also on clinicaltrials.gov. That phase 2/3 trial is still recruiting. And therefore, if you feel you might be a candidate for that, it'd be great if you can get some more information about this trial through our website, which is ProQR.com, or through the FFB. And hopefully, if you're eligible for the study, it'd be great to have you participate in that study. And like I said, the recruitment is still open at this stage, and especially as we come out of the COVID-19 situation, it's going to accelerate recruitment as well. So looking forward to getting some more participants there. One other question has also come up that I see, what's the difference between RNA therapy and gene therapy? And that's a common question that I get asked, and I maybe take the opportunity, Ben, at this stage just to give a quick overview of that. So RNA therapy, as we mentioned, is very specific. It doesn't necessarily alter the DNA, but focuses on RNA itself, as opposed to gene therapy, which is focusing really on modulating the DNA. The RNA therapy typically requires redosing, which was another question that came up. Our RNA therapies so far have required dosing twice a year, so 6 monthly injections, and these are injections into the vitreous cavity, so a simple outpatient procedure. We know that gene therapy, the advantage of gene therapy can be that it's potentially one and done. And so that could be a very significant plus for gene therapy there. Typically, gene therapy requires a very invasive procedure, which is often needing to have general anesthesia and a subretinal injection, which is a very complicated injection, and it requires experts such as Tim and others to be able to perform those. As opposed to RNA therapy, which is a much more simplified procedure, it does not require general anesthesia. It can be done in the office situation, in an outpatient department, and it is a simple injection into the back of the eye under topical or local anesthesia, so you don't feel the pain. And many patients who may have had wet age-related macular degeneration, who get frequent injections like this, would know this injection procedure very well. Typically, the RNA therapies would be reversible. So if you do develop any harmful side effects, you can potentially allow the drug to be eliminated out of your body with time. Gene therapy, of course, remains in your body, and so far we've not found a way of being able to neutralize that. One other important facet to note is that whereas gene therapy really focuses on a certain area of the retina, and typically we focus on the central vision area of the retina, around in the macular area itself, usually diseases such as retinitis pigmentosa and some others, it usually means that you can only focus on the end stage of the disease, when the peripheral retina is degenerated and now you're focusing on the central area in the macula. Now, that's not always the case, but typically that seems to be the case with most gene therapies that we're seeing here in the clinical trials realms, and indeed some of the newer gene therapies coming through with gene editing as well. That's in stark contrast to RNA therapy, which is the injection into the vitreous. One advantage of the RNA therapy is that it allows you to get the drug to all parts of the retina, because you're coming in through the vitreous cavity, and therefore potentially you can treat diseases at a much earlier stage. And so that could be potentially important there as well. And lastly, what I would say is that RNA therapy doesn't require some of those vectors that Ben talked about, the AAV or adeno-associated viral vectors. These are the kind of host molecules that carry the cargo into the eye. RNA molecules can be naked molecules. Typically, gene therapies do require those virus particles, which are harmless, but are really the carriers of the actual cargo into the eye. And so really, depending on how big that cargo is, will also determine what kind of therapy could be used as well. So I hope that gives a quick overview of potentially the contrasting differences between RNA therapy and gene therapy at this stage.
Excellent discussion. Thanks.
I think we have probably one more question that we'd be able to squeeze in. So there's some questions around Usher syndrome and a lot of the therapies going out in clinical trials. Are they focused primarily on vision, or are some of the treatments and trials also looking into improving hearing?
Okay. Yeah. So we have an Usher's trial going on at the moment, phase 1/2, which is partly funded by the FFP that Ben talked about. Essentially, we're only focusing on the vision component of this. Typically, the hearing elements with the new cochlear implants, especially the digital ones, many people are taking advantage of those. There seems to be, a reasonable amount of function that can be restored there. But of course, unfortunately, the vision component of it isn't. It's really a high unmet medical need still. Patients still go blind with that disease, and so we're focusing hard on that area. And so we have some interesting results which are looking at sensitivity of the retina and also central visual acuity, and those are the trials that are ongoing at the moment.
Great, perfect. Ben, I think that's all the time we have questions for. I'll hand it back over to you.
Okay, great. I want to give a round of applause to our experts, Dr. Girach, Kari Branham, and Dr. Stout. Thank you. That was a really excellent panel. And I guess from there, we hand it back over to Donna to close this out.